So we're going to do diabetes today. The roads aren't terrible. Actually, didn't take me that much longer to get here than it normally would. So there's that. And I'll try and get done by 5 regardless of where we're at. Just give you guys a little bit extra time to work with. So anyway, diabetes. We're going to talk about type 1 and type 2 today. But first, the rule of thumb here is all going to be about sugar and how the body processes it. So we have to take that into consideration when we're talking about our drugs, and that's going to be how everything works. And a lot of things are going to be worked through the mechanism of insulin and how that utilizes glucose, and also some things like storage and things like that, but less involved with some of our drugs. But we'll talk about the different mechanisms as we get to the medications. This just talks about insulin and glycogen energy and glucose release and that type of stuff. Not going to test you on it, just kind of fun to talk about. Diabetes has a couple of complications that are important to think about as we go through the lecture today and think about context and why we want to manage people's glucose within a tight range and an appropriate range. So two major sides of the complications, macro and microvascular. So macrovascular would be things like stroke and heart risk, and also some other things like peripheral vascular disease would also fall into that category as well. A lot of times these things go hand in hand with high blood pressure, high cholesterol. They used to use a term called metabolic syndrome. I'm not sure if that's appropriate or not, but it's sort of like the whole trio where you get you have high blood pressure, you have cholesterol, you have diabetes, and also obesity and BMI fell into that at some point too. But anyway, the point is that these things compound each other. So if you think about having a lot of extra glucose floating around in your bloodstream, plus high blood pressures on top of that, that's going to compound the effects that glucose has in wearing down, especially in microvasculature. So those capillaries, think about how they're processing things going through from side to side, and if you have extra solute in there over time, that just wears things down more quickly. You get damage to blood vessels and ultimately damage to nerve endings. That's what causes things like retinopathies in the eyes. Renal issues are one of the most profound things we see with diabetic patients, and neuropathies also would be a primary source of patient pain. So peripheral neuropathy management. Talk a little bit more about that during the neuropathic lecture, but it's mostly during neuro. I'll bring back neuropathic pain a little bit, but we already touched on that a bit during pain, and it's really the same whether you have neuropathic pain from specific injury or from long-standing diabetes. You treat it and manage it the same way. Okay, type 1. Type 1 is one of the most common chronic diseases affecting children, but also, of course, kids will take this into their adulthood. It's autoimmune disease that currently we have no cure for. However, there might be interesting things on the horizon, such as artificial pancreases and things like that. That's currently not available, but I wouldn't be surprised if we start to see that, within the next few years. Possibly a few, maybe 5, 10, who knows. But anyway, there's some cool technology out there that we're utilizing right now that I'll talk about with insulin delivery. But first of all, so type 1 specifically is insulin-dependent, diabetes. And what that means is that you aren't going to be able to treat this with oral medications. So it might sound obvious, but you can't manage a type 1 diabetic patient without insulin. You have to supplement the insulin somehow. That's because they have an autoimmune disease that is having the beta cells of their pancreas slowly being destroyed. So most people, your pancreas is born with a certain number of beta cells, and over time, if you have type 1 diabetes, your body's slowly going to deteriorate that pancreas until you present with symptoms of hyperglycemia because you have no insulin, or not enough usable insulin circulating and available for your body to use. There's a lot of different genetic and environmental components theorized as to why people get type 1 that I think are interesting, but beyond the scope of this course. And again, insulin-dependent diabetes is the name of the game. I just put this up here. This is a prevalence chart. I think it's interesting. You look at people of European descent tend to have much higher prevalences of type 1 diabetes than other ethnicities like Latin America, African ethnicities, Southeast Asian. So I don't know. It's just I'm not saying that there's something in the water that Europeans and people of European descent are drinking, but it makes you wonder why, like, for example, Scandinavia and higher latitudes have higher amounts, and then Australia being kind of a weird outlier in a region where there's not a whole lot of high prevalence, obviously being a British colony at one point, though. So there is some, I don't know, again, just interesting speculation there. You can get on your vitamin D deficiency conspiracy theories if you want, but I don't really, I don't really know. I don't think there's a great idea of what is causing it, but it is an interesting trend. As far as onset, you're looking at two major onsets. You're going to see people present with type 1 diabetes. It's going to be usually between 4 to 6 years, but also between 10 to 14 years is a common presentation time as well. About 45% of people present before the age of 10. So you have about a 50-50 mix between those two groups. There's no gender difference. Females have a higher incidence of autoimmune diseases in general, but type 1 diabetes is about equal between the two genders. Incidence is rising, but that is possibly due to increased documentation and people catching it earlier. So who knows if that's actually incidence rising or just better documentation and better screening tools that are catching it at an earlier age. Genetic susceptibility, I don't care that you know this, but again, it's just interesting that there's some genetic component here likely, but it's not a super high correlation. So anyway, skip that for now. All right, so diabetes symptom onset is going to be pretty similar between the two, and it's usually just because you have too much sugar in the blood, and it's going to present the same way for each patient. But the real question is going to be patient history, and usually with people who are type 2 diabetes, you're going to see some signs leading up to it, right? There'll be hopefully some medical care that involves pre-screenings where you see maybe some hemoglobin A1Cs and blood glucose is trending up slowly. You maybe try diet and exercise for a while, it doesn't work. With this patient, it's going to be a kid that presents with some of these symptoms suddenly. So if you plan on going into pediatrics, it might be something you do see presentation-wise. Polyuria, so excessive production of urine. So when your blood glucose gets high, your body tries to excrete it out via the kidneys. It's a natural compensation mechanism. So in kids, you might see increases in bedwetting. If the child is potty trained overnight and all of a sudden they start wetting the bed again, that can be a sign of early diabetes as well. Polydipsia, excessive thirst. Again, your body's trying to compensate, so they want to dilute out the sugar, so you try and drink more water. And weight loss. So hypovolemia and increased catabolism and impaired glucose breakdown can cause symptoms related to nausea and anorexia in extreme cases. So the child might develop those and stop eating, and that will cause some weight loss. Where generally speaking, you're not going to see that complication quite as much with the type 2 patients unless you see a really sudden increase in sugar, or they're in like a hyperosmolalnic state, which is a different type of picture, which we'll talk about very briefly here. But talking about insulin, so of course the body produces insulin in the pancreas, and we can supplement it with a variety of different products. So this is going to be required therapy for any type 1 patient. It also has a big role to play in type 2 management as well for certain aspects of type 2 management. We'll get to that in a few slides. Therapy is going to start with diagnosis of the disease, first of all, and then our goal, we want to prevent the long-term complications. So really, if we manage type 1 diabetes correctly, you can give people a fairly normal life. And it depends on how, what type of access of care the patient has, if they have a caregiver that can help them with this, if they understand how to drop insulin doses and how to do some carb counting and things like that, that can really help and be beneficial for the long-term goals. But we can do really cool things like continuous infusion pumps and make life really easy for these people. You know, ultimately they're still going to have a chronic illness that requires management, but there's some nice strategies we can do that help in the long term. And I think the more, unfortunately, I guess, the more, what am I trying to say? The more competent your patient is, the higher end technology they're going to get. So you put we're jumping the gun a little bit here, but you put like a continuously infusing pump on a patient who doesn't know how to manage it, and that's a risk for hypoglycemic error, whereas they might be able to manage twice a day shots a lot better than that. So we'll talk about those different strategies here, but there's a lot of different ways we can go about this, but some preferred ways and some maybe not so preferred ways. So pre-treatment, for a while, type 1 diabetes was just managed with a couple daily injections. And for somebody, maybe a child who's very early, maybe they caught it at the early stages, but the pancreas is still making a decent amount of insulin, so you aren't seeing really high blood sugars yet. You could get by with upping their insulin load for like a basal rate just a couple of times a day. But generally, that's not going to be an effective strategy and certainly not a long-term strategy. So most likely, you're going to start with intensive therapy for a type 1 diabetic patient. And intensive just means you're trying to mimic physiologic insulin, so it's multiple injections a day. So that means every time you eat food, your body releases insulin in response to increased blood sugar. That's how you want to mimic that. So you want to give somebody a shot of insulin before they eat their meal so it can absorb and get active and in high concentrations in the body so it can be used right as their blood sugars are peaking. So we try and time those slightly before meals. And then we provide basal insulin too. So we'll talk about those different products and the general strategy for that. The drawback, of course, with this strategy is that you have multiple injections per day, and a lot of patients are just going to have difficulty with this right off the bat. Unfortunately, for a diabetic patient, they're going to have to get used to sticks. So they're either testing their blood sugar by pricking their finger, or they're injecting insulin. If they get on a pump at some point, that's a sub-Q pump, so it's hooked in. They don't have to regularly inject themselves. That could be a nice way to get around that at some point, but you're going to have to start a regimen somewhere, and usually that's going to involve some needle sticks. So yes, it's not the most convenient thing, but it really is the best way we're administering insulin. There's no other way to administer insulin currently that's effective. There was a product on the market maybe about 10 years ago that was an inhaled insulin, and the thing was like, I don't know, it was like this size maybe, and it actually slid up, so it became double the size, and you would inhale it. I don't know. To me, it looked kind of like a bong or something. Not to use drug paraphernalia references, but that's what it reminded me of. And you would it's had this big mouthpiece on it. It just was the most. Could you imagine pulling this thing out before your meal at a restaurant and thinking, oh, I'm just going to take my insulin? It just looked really weird. And sure enough, patients hated it. And you also had to use it quite a few times a day. It wasn't the best bioavailability of the product, but insulin can be absorbed through the lungs. It just, no one's come up with a great way to do it that's convenient for patients. So for now, it's all injectable. Two major types of insulin presentations that I call the old and the new way would be vials and syringes versus pens. So you can still get patients on these, and oftentimes vials are just more of a bulk product, so they're going to be less expensive. So if somebody has cost issues with affording pens, vials and syringes might be the better way to go. There's no difference between the products, but the pens are just much more convenient, and I'll show you some of those details here in a second. But basically, these syringes have gradients on them that are in units. So most insulin, and you can see on the bottom of the slide here, is usually per mil, and it's units per mil. And generally speaking, almost all products are 100 units per mil. There's a couple differences, which we'll talk about, but usually you can think about it that way. So the syringes are gradient in number of units. So the patient can pull back to 10 units, 20 units, whatever, so they don't have to do the math, which can be a little bit confusing. So make sure you're dosing properly and not telling them to inject 0.1 mils. Well, that might be correct, but their syringe might not say mil. It probably says unit on it. It's an insulin syringe. So most people don't have that issue, but just so you're clear on that one. Pens are devices that all pretty much look the same. They vary a little bit in how they click and how they twist, but for the most part, they all look like this. And they're going to have a window on it that has a dose counter. So that's how many units you're injecting. So it doesn't tell you how much you have left, although you can see the volume in the clear part. This is your medicine here. There's nothing really in this part of the pen other than a delivery system. Here's where your medicine is. So there's 3 mils in a pen, so you get about 300 units of insulin. There are some more concentrated products, which we'll talk about. And what somebody's going to do is they're going to dial this twist thing back up to however many units they want to give, and then they're going to put a pen needle on the top, which is this thing. So these are little sterile needles that come as a separate supply that you twist on to the end of an insulin pen, and you inject that subcutaneously, usually just by pressing the button down. You don't necessarily have to hold, but some of them are different. Some require just one press, others might require a hold. Just depends on the product and who's manufacturing it, but they're all very similar. Yes?
If you use the syringe method, you have to switch the syringe every injection?
Yes, so it's a single use. And same thing with the pen needles, they're single use. So every time you do that, you'd want to throw that away in a sharps container. Yep. I mean, technically you wouldn't have to do that, but you're risking sterility and contamination and all kinds of gross things. So I wouldn't, but some people might do that. You never know. Yeah, definitely I wouldn't recommend taking it out and recapping it, but you might see patients do things. I've heard of weirder things in my life. But that's basically pens. They have a little cap on them like this that covers it when it's not being used. And then again, the end is a Lurlock tip, so you can adjust it that way. Most pens either go up to a total of 60 or 80 units per injection. So if you get a patient who is using a ton of insulin, which happens, I've seen patients doing 100 plus units BID, so then they're just going to have to do 2 injections. And you could probably use the same pen needle with each one during that time period as long as you kept the area clean. So you do 1 injection of 60 or whatever the max is, and then you'd go on the other side and do 40. So that would, again, require a little bit extra, and obviously you're doubling up on your injections per dose. So that's a little bit complicated, which is where these new concentrated products can come into play. We have some 200 unit per mil and 300 unit per mil products on the market right now. those can be helpful for patients on really high doses. So some options. We have a couple different types, and I really say there's three that insulin fall into: basal, intermediate, and rapid acting. Basal insulin or long-acting insulin are going to be designed to mimic your body's basal insulin. So you always have some insulin circulating for immediate response and having it available so that you can process glucose appropriately. And that's these three products here. Intermediate acting, or insulin NPH, and regular insulin kind of fall into this category. Regular insulin is how it sounds. It's actually structurally identical to the endogenous insulin your body makes. And it's a bit faster acting. I'd say it's kind of in between a rapid and an intermediate. When you give it subcutaneously, it does take some time to absorb, and it's a bit slower onset than something like the rapid acting ones. However, if you gave it intravenously, which you can actually do with regular insulin, so we use that in like crises if somebody is really hyperglycemic. There's some other applications for IV insulin as well, but this would be a medication that's one of the only ones you can actually do IV. So most of the other ones we're looking at sub-Q, which does delay your absorption a little bit getting into the bloodstream. Here's just a general chart that shows a little bit about comparing relative effects from absorption and time. So we see our endogenous insulin here. Of course, that gets into the bloodstream immediately. It doesn't have to absorb subcutaneously. And all these are assuming sub-Q absorption, so you have a little bit of delayed onset. You're looking at probably 30 minutes maybe to seeing peak effects, which is why for most times people are going to be injecting mealtime insulin about 30 minutes before they eat their meal. You have some long-acting ones. So for example, here's they say NPH is an intermediate here. You can see it's got a bit more of a peak effect, whereas a long-acting like Glargine or Detamir, they don't really have a whole lot of peaking. So they pretty much just get to a steady state and then very slowly wear down, which is really nice for basal insulin, because the idea is that you might, if you're always having that on board, then you avoid those peaks and possibly avoid excess hypoglycemia, which is going to be your biggest side effect with insulin, right? Overdoing it and getting hypoglycemic. All right. This next slide shows a variety of products and their brand names for your reference, and just some relative time comparisons on how long it takes to work. So like again, a rapid acting, less than 15 minutes, maybe 30 minutes at most, depending on how much adipose tissue the person has. It might take longer to absorb. Glargine, you're looking at, again, a long-acting basal insulin. That's going to be 4 to 6 hours for it to absorb. So if you gave somebody a dose of Glargine, don't expect any results right away, but that's not the purpose of Glargine. It's supposed to be there later, not immediately. It's not an acute acting medication. Same thing with Detamir. This chart's a little old. I don't have what's it called, Traceba or Degludec. That's a new product, and I'll talk about that in a little more detail in a second here. But that one would be similar to Glargine. It's got a very slow onset. A little bit longer acting, though. Its duration is more like 36 hours, which might have some advantages in not having as much overlap, or more overlap between doses if you're dosing it once daily. Okay, so Glargine basal insulins, there's three choices. Basal insulin, three choices: Glargine, Degludec, and Detamir. Glargine has long been the preferred option, and it's been the one that best mimicked basal rate. Detamir, even though that other chart I showed you kind of combines them as two, Detamir has a bit more of a peak to it, and a lot of patients find that they don't get a full day's worth out of it. So usually Detamir is dosed twice daily. Whoops. What happened to my mouse here? Where all these other ones are going to be once daily dosed. Every once in a while, you'll see patients split up their Glargine or their Lantus into 2 doses, and sometimes people just don't get full effects from it. So kinetics can vary, just like with any drug, and absorption can depend on the person. So some patients might get great 24-hour response. Other patients might respond better to a Q12-hour type dosing strategy. It just depends on the patient. But usually for the top 2 bullet points, you're looking at once daily administration for most patients. So you have a couple different options here. Lantus was the first product that came on the market that was Glargine, so it's probably the most common one people will call their insulin. Most patients never call their insulin Glargine. You're never going to hear somebody say that. That's the generic name of it. Lantus, again, the first product, it's a U100 dose. Toujeo was a new product that came out like a year or 2 ago, and it's a U300 product. So again, if you have somebody on 150 BID of Lantus, it might make sense to switch them to a Toujeo because they're going to be going through a whole pen in a day. And not only is that expensive, but it's just a lot of maintenance and a lot of waste too. So if you can get the people transition to these higher dose or higher concentration products, it can be really helpful for them. It gets complicated though. You can imagine if you have a patient who's used to injecting 150 units, and then all of a sudden they're on a product that's much more, just making sure that they understand and that you're going through the product with them. Hopefully a pharmacist will explain it to them, but I think it's good, especially when you're talking about concentrated insulin. It's probably one of the most high-risk medications out there because if you overdose yourself, if you shoot yourself with like multiple injections of Toujeo and you're using triple the amount you should, that's going to last in your body for 24 hours, and that's a huge amount of hypoglycemic risk over a long period of time. So insulin's always one that I get really nervous about, and I've seen people come in who mess this up, and you would think it's not possible with a pen. You'd be wrong. People just don't understand. Like, for example, somebody might be used to cranking their Lantus all the way out to the max, and they get on a new concentrated one and they do that again, and of course it's triple the concentration. So education is really key with these concentrated ones. Again, very high risk, but really convenient for patients who it applies to. Basaglar is sort of a generic Lantus. I hesitate to use that word because it's not really. Insulins are pretty much like a biologic product. They're a peptide. So they're produced in different ways than our small molecule drugs are. They aren't technically biologic. They don't really fall into that category totally, but they're more like a biologic than like, lisinopril, for example. So anyway, they're expensive, and making them is a little bit tricky compared to making, any type of small molecule drug. Basaglar is sort of a generic version of Lantus. It's a little bit less expensive, so you might see patients on it. It's supposed to be structurally identical to Lantus. Just has a different brand name on it. Again, about a 24-hour duration with glargine products. Degludec or Tresiba is the new product. It comes as a U100 and a U200, so it's two different concentrations. It's got a 24-hour half-life. It takes about 3 to 4 days to get up to steady state. It's a brand new drug, but it has good data in both type 1 and type 2 diabetic patients, so it's been studied in both populations. And one of the preferred things about this product is it's thought to have lower nocturnal hypoglycemia reported. One of the things about Lantus, a lot of people take it around bedtime, around dinner time, and what can happen is you might get a very slight peak. So even though Lantus's blood concentration is pretty flat, you probably get a little bit of a peak and then a slowly tapering off as it gets eliminated. But with this product, it's supposed to be a little bit flatter, and they just don't see the hypoglycemia you might get with somebody who takes Lantus at bedtime, and then 2 hours later into their sleep or 3 hours later they're getting hypoglycemic. So that is something that does happen with Lantus. You can move Lantus during the day and do it in the morning, and then hopefully they're going to be able to monitor better for that, and that's an option too. Or you can split up their dose into AM and PM, and that might help keep it flatter as far as the basal rate that's in the body. But Degludec's designed specifically to avoid that. So that's where its big advantage is. And I think depends on who you talk to, but I know that there's a lot of, I did a big review thing on this the other year, but it's a big CE thing, and I think especially the American College of Endocrinologists, I think, is getting more and more on board with this. But it is a more expensive product. It is a newer product, so you may have insurance barriers, and I don't know how well it's going as far as if people are just prescribing it right away and if it's getting covered or if they're getting some resistance. They're like, no, because I'm sure Lantus and Basaglar especially are quite a bit less expensive. But all insulins are pretty expensive. There's not a whole lot of cheap insulin out there, with the exception of a couple we'll talk about here. So these products are all going to be relatively costly for patients. And of course, the newer ones, Toujeo, higher concentrations, and Degludec, those are going to be the pricier options of the three, or of the several we have on here. And then Detamir. Detamir is not to be forgotten about completely. A lot of patients use it, but I think that generally speaking, you're looking at a better advantage with some of the other ones. Some insurances might direct people to prescribe Detamir over a Lantus product or a glargine product, but it just depends. So I would personally probably stick to the top 2 bullet points, just because they do have a flatter peak, less likely to cause hypoglycemic response, and are going to provide a more physiologic basal rate. But if you're leaning towards Detamir due to cost issues or insurance coverage, it's not a bad thing. You just want to dose it twice a day. So where you kind of have the option to play around with glargine and Degludec dosing, whether it's once daily or twice daily, with Detamir, you're always going to want to dose it BID. Mealtime insulin. The three rapid actings are all interchangeable and are basically the same. Their kinetics vary very little. So where the other ones have some differences, these really don't. They're essentially the same. Insurance is going to cover one or the other, and that's pretty much the end of the story. This is your one of these three is going to be your mealtime insulin of choice. Humalog as a brand name, which is Humalog is Lispro, and Novolog is Aspart. Humalog comes as a U100 and a U200, so there's a concentrated version of Humalog. So again, if you're having a patient who's using a ton of mealtime insulin, might be a sign that you need to up their basal rate a little bit. But at the same time, you could up their concentration of the Humalog to U200 and allow them to inject less volume. Onset about 0.2 to 0.3 hours. Peak is about 1 to 3 hours. Duration about 3 to 5 hours. So I get this question a lot. I want to give some patient a little bit of insulin. What's the duration? How long? Or the patient injected way too much of their mealtime insulin. You know, maybe they do 100 units of Lantus in the morning and they accidentally gave themselves 100 units of Novolog. So on an empty stomach, you know, how do you deal with that in a critical response? That could be potentially life-threatening. So you want to make sure you understand your kinetics on these pretty well. I'm not going to test you specifically on the hours or anything like that. But I do want you to know rapid versus long-acting. So just know the general differences, and I think you'll be okay. Obviously, anytime somebody tells you they tripled their insulin dose or something like that, that's a big deal. Should be a big red flag, but you will get those situations if you work with diabetic patients for sure. All right, some other regimens that are not as favorable. NPH, which I can never remember what this stands for. It's like neutral protamine Hagedorn or something like that. Some guy named Hagedorn figured out you could take, he isolated protamine from some kind of a fish semen or something. It's a really weird process. And anyway, he mixed it with insulin and realized it added a chain to it that gave it longer lasting effects. So anyway, NPH was it's an older drug and it was one of the first insulin analogs to come out that was actually longer lasting than regular insulin. So it's an option as a twice daily drug for people who probably can't afford one of the more expensive basal ones. And that's really its role in therapy. Sometimes you'll see NPH used in other situations. We're going to talk about it a little bit with gestational diabetes. It's got some good pregnancy data. Again, it's an older drug. It's got more evidence. It's been around a little bit longer. But other than that, NPH has fallen out of favor. It's not long enough to mimic basal rate. It's not short enough to mimic mealtime response. So really, its role is a bit of a middleman. And where I see NPH used is a twice daily for people who, again, can't really afford or can't comply with a more intensive insulin regimen. I've seen people try and get prescribed like a basal plus a mealtime strategy, and they just don't adhere to it. So they're like, well, I got to get this person some insulin somehow, so I'm going to try NPH twice daily and hope something works better than nothing. That's a strategy too. You know, you try your best with people, but sometimes you just got to work with what you're given. You can't force somebody. You can't be with somebody every hour of the day, of course. So NPH might be an option for those patients. And again, it is less expensive, so there is that advantage there too. Regular insulin is rarely used on its own. It's if you did use it on its own, it's about a 3 to 4 times daily dose. It does come as a U100 and a U500. So this is one of the weirdest ones is U500 insulin, and one of the most dangerous products probably on the market that exists in American healthcare. U500 is one of the easiest things to mess up. The reason is it doesn't come as a pen, although I actually think they started making it in pens now for safety reasons. But a lot of times people are buying U500 because they're on really high doses of regular insulin. It's cheap. So regular insulin, both as U100 and U500, quite a bit cheaper than anything else we've talked about. So if you're looking for a cost alternative and you see somebody on regular insulin, it's likely because there's some sort of insurance issue. Maybe they don't have coverage, they're paying for it out of pocket, whatever it might be. But U500 could be an option for people who are just injecting so much volume because they have such high doses that they need a more concentrated formula. The problem is that it's really confusing because people might not have pens or syringes that are correct. So what we have happen in the hospital, this happens all the time, which is a little scary, but I'm always really careful when I talk to people about this, is people come in and say, oh yeah, I'm doing 15 units of my U500 3 times a day. I'm like, wait, you're doing 15 units of U500? That's like a microscopic amount of volume. How do you even draw that up? They're like, no, I take a regular insulin syringe and I pull it up to the 15 and I inject that. Well, that's actually 45 units 3 times a day. So you have to make sure that you're really careful when you're talking to patients about U500. I've had providers order it where it's like 15 or 25 units, and it just doesn't make any sense. You got to think about the volume too. So 500 units per mil, if you're ordering like a small amount, it's going to be tiny. You aren't going to be able to measure that. They do make U500 specific syringes that will dose it properly, so it's designed to be set up for that volume. But again, you have issues with that too. So the best thing is to give somebody an insulin syringe and say, "Is this the one you use at home?" They'll look at it and say, "Yes." Show me how much you inject. They're going to pull it back, and then you can gauge it from there. So that's the strategy I usually go with if a patient's having trouble. But it's really important to double check that in any setting you work in. Okay, so again, relatively cheap. Sometimes you'll see things where you have like levemir and glargine twice a day, plus maybe like a Novolog thrown in there. Anyway, some weird stuff like that. Oops. Some of the other ones, where did I go here? Some of the other ones that are on the market, there's combinations of short-acting and intermediate and short and long-acting products. I don't know how much utility these have. I feel like these are less common than the other styles, but you get maybe some advantage if you're looking at combining a morning mealtime plus a morning basal rate. So like Degludec, that manufacturer just came out with an aspart combo called Rhizodeg, and you've got a administration in the morning, you're giving it, and then you're getting your mealtime too, potentially. I don't know. It's a little bit tricky because it's hard to titrate those individually. So again, utility-wise on these, I'm not exactly sure how well they're accepted in the endocrinology community, but I think I would prefer to do them each separately personally. But that's just me. So back to our type 1 diabetics. If we're looking at a new patient, your general total daily insulin dose is going to be about 0.2 to 0.4 unit per kilo per day. And then eventually you're going to titrate them up to about 0.6 to 0.7 units. Now, it's all depending on how they respond to it. You, of course, want to make sure their blood sugars are within range and not get hypoglycemic. That's really the goal here. Nice thing about insulin, you can adjust it quite frequently. It's easy to make small adjustments on a daily basis to really hone those patients in. Basal can be a little bit trickier to adjust, especially if they've got Degludec. You're looking at a couple days to see the changes, but mealtime insulin is really easy to make alterations in short term. Teenagers might need even more, so remember keeping in mind your patient population. These are new patients, kids, teens, can require a lot more. So if you're over 0.7 unit per kilo and you're still titrating them up, don't be too surprised. Usually what we do is, so once you get your weight-based dosing, you're going to put about half of that as basal, and the other half's going to be given as mealtime insulin. That's the most common strategy here. Remember to split it in half if you're using Detamir and do it twice daily. And then, again, the rest is going to be mealtime. So basal is pretty straightforward. You just usually do one dose a day or maybe 2 doses a day, depending on the product you pick. Mealtime can be a little bit more challenging, and this is going to depend on how your patient is able to comprehend some of this information and how they're going to be able to do carb counting and sliding scale interpretation. So ideally, you're going to have a couple of different parameters on board, which is carb counting plus a sliding scale is probably the most common thing I see. So most patients will inject a certain number of units per carbohydrate choice they're eating with a meal. So like 3 units per carb choice, just to throw a random number out there. It might be 5, it might be 1, depends on how the person responds to it. But if they're good at carb counting, so maybe they're going to eat 5 carb units in a meal, I don't know. So they're going to do 15 units of insulin before that meal. Now, what they're also going to do is a sliding scale. So after they're going to also check their blood sugar before they inject, and maybe their blood sugar is really high. Maybe it's like 250. So they're like, whoa, what's my sliding scale say? So they go over and say, I'm supposed to add on, 250 would be 2 units. So then I add on 2 units to my meal times. Does that make sense? So in a baseline, you would carb count for your meal, and that's what's going to compensate for what you're ingesting. Plus, you want to do the sliding scale on top for whatever residual excess blood sugar is already in your body to help get that processed via the insulin. So that's a really common strategy. That's probably one of the better ones out there. Again, that requires some patient learning curve, right? You have to be able to carb count. You have to be able to interpret your sliding scale. You have to do a couple different injections, do some math potentially. If you do your carb counting and inject it and then forget about your sliding scale and then you do it later, that's 2 injections. So not the end of the world, but again, you have to be on top of it a little bit. What I'll see sometimes done is, if a patient's pretty consistent with their diet, sometimes you'll see fixed dosing. So maybe they just 10 units every meal. Maybe they use 9 sometimes, they use 8 sometimes, they use 12 sometimes, but it averages about 10. They're pretty consistent eaters. Let's just go with a fixed dose. It seems to be working well. That's a possibility. Usually it's not best practice, I would say, but for a patient who might struggle with a carb counting strategy, it could be an option for them, especially if they're, again, consistent with their intake. And you can have a fixed plus a sliding scale. So maybe they struggle with carb counting, but they can do sliding scale. That would be an option too. I've had a lot of patients come in and tell me odd things, like they even will do their basal insulin on a sliding scale. So they're like, well, I'll check my blood sugar at bedtime. If it's really high, I'll give myself a little bit extra Lantus. And like, I don't think you're being prescribed it that way. So don't be surprised if you hear people getting creative with their insulin doses. And some people might say, well, you know, I didn't eat much that day, so I only did this, and I kind of skipped lunch this other day, and so I didn't do my insulin at lunch. And of course, you don't generally want somebody to inject a bunch of insulin if they're eating anything. So, and you'll hear all sorts of things from people. But generally, if you're thinking about 3 meals a day, maybe, you know, a bedtime snack or something like that, this is a pretty common strategy you'll see done. Yeah.
Is the sliding scale meant to like before they check their blood sugars, and if it's high, then they give themselves some fat based on what their level was, and then
Yeah, it's an add-on to whatever they've got.
People don't usually just do sliding scale.
No, people don't usually just do sliding scale. Yeah, you might see sliding scale done in the hospital, right, as just an add-on to somebody who's not necessarily diabetic or maybe pre-diabetic. But yeah, it's not commonly done. It wouldn't be a good practice just to use sliding scale. Yeah, it's usually an add-on to whatever they've got as their baseline. Yep.
So they have like a list of 1 unit of a carb choice, or how do they decide? Is it a piece of bread? Or
Yeah, I don't. This is where I don't know. Yes, exactly. This would be a dietary consult.
So it's like 7 grams of carbs.
No, it's based on 15. Everything's based on 15. So like a slice of bread is typically 15, depending on how much rice can you eat for 15, how much noodles can you eat for 15 grams, and then they adjust the insulin based on that 15 grams. So some people might go as low as a half a unit, some people might eat 3 or 5 units.
Doesn't matter if it's like rice, white rice versus oatmeal or soy.
There's some fiber, but that's like, you don't even need that for a new patient because that's way too complicated.
I imagine there's apps and stuff out there that help people with this now, are there? I don't know. I've never really looked into it, but as technology's gotten better, I assume people have tried to do some of this stuff. But yeah, I don't know. If your patients are tech savvy, I'd encourage them to try something like that. But yeah, it's definitely interesting. And when you get into the carb counting, for sure, a dietitian is going to be your friend in referring them there. Yeah, you have to see a dietitian. It's a good point. You have to see a dietitian if you're any type of diabetic. Yeah, for sure. I would. Yeah. Okay, monitoring. So a lot of different systems out there. They all are basically the exact same thing. They just look different or are more convenient or have cooler colors or different displays. So you basically have a machine that is able to put a strip into it, and you prick your finger, put blood onto it, and it just takes a small amount of blood. It kind of sucks it in. Have you guys ever done this before? Did you do it as part of like a lab as part of your school here? Okay, good. It's good to everybody to try this at least once. This is relatively inexpensive. The machines are usually free, but the strips are where they get you. So it's kind of like, you know, razor cartridges, right? Same concept there. You have insurance that's going to pay for these in most people, unless they don't have any insurance. I've never seen insurance not cover test strips. They might pay for a specific brand, though. So they might say, oh, but I would suggest prescribing, and what I see a lot of people do is write prescriptions for test strips, whatever brand the insurance covers. And that's a way that you can get around having to call back to the pharmacy and be like, you prescribe BD, but they only cover, you know, whatever other random brand you can think of. Anyway, it's pretty simple to use. A lot of these have been designed to basically be very low functioning people should be able to use these. They pretty much involve small buttons small amounts of buttons and large displays that tell you what you need to know. A lot of them have a storage and memory built into them, so you can like interrogate their meter if you want. You can go back during a visit and look at like the last 30 days of readings. Some of them link to smartphones now, and that's a pretty cool advantage. So they can have it all in like a graph, and there's some really cool, again, technology is getting better and better in helping out our diabetic patients. And so they don't really even have to think about it. You can show them this chart. They can look at where they're peaking and where they're low. It can really be helpful as a prescriber adjusting their insulin dose at certain intervals. 4 to 7 times daily testing is pretty common. Minimum at mealtime and bedtime. Sometimes patients, if they work out during the day, that's a good time to test too. If they're having an extra snack or something like that, another good time to test. Single blood glucose is only a snapshot, so trends are really what we're concerned about. One blood glucose doesn't really mean much, unless it's like 700 or 1,000 or something crazy. A single blood glucose, if it's 200, you're like, well, let's see what else you've been the rest of the week. Hemoglobin A1C. Now, for hemoglobin A1C in type 1s, we don't really care. That's more of a type 2 monitoring thing. We'll get to that and the guidelines for that. But I just put it on here because it's the more long term. So you can look at hemoglobin A1C. It's going to show basically a snapshot of what your blood glucose has been like for the past 2 to 3 months. And goal is usually less than 7 or less than 6.5. And we'll talk about those guidelines here in a couple slides. All right, continuous infusion. So continuous infusion pumps are going to be filled with short-acting or rapid-acting insulin, and there's going to be usually regular Lispro or Aspart. Lispro and Aspart are the two common ones I see used a lot. And it's just going to be providing basal insulin, but in a continuous rate. So it's constantly giving your body rapid-acting, so it's not lasting very long. The nice thing about that is that you have a fail-safe mechanism. If you accidentally pump malfunctions or something like that, your body isn't going to get overdosed with insulin because it's going to wear off hopefully pretty quickly. But on the flip side of that, you run out of insulin pretty fast. So you can get hyperglycemic if you don't realize your pump's malfunctioning. Let's see. Initial pump dose about 10 to 20% less than an injection regimen. So usually pumps are just that much more efficient. You don't have to go as high of dosing. So you'd look at, if you're converting somebody, you'd look at, okay, how much basal are they using and how much mealtime do they use on average? Let's do about 10% of that, and let's start with the pump. And pumps can be designed to give boluses. People can bolus themselves off their pump based on their blood sugar. And some pumps now even have these cool ways they can communicate, like with Bluetooth, where they can talk to a sensor. And of course, this requires wearing a sensor, which, who knows if people will actually do this. But there's options for these things out there, and there's technology that exists that allows the sensor to communicate directly with the pump and tell the pump that I've got, too high of blood sugar, let's give a little bit extra. Or it can sense if the person's getting hypoglycemic and give a warning that way. Some of the infusion sets actually might have sensors built into them now. Again, technology is getting better. Pumps are it's pretty easy to get somebody on the phone that can help with the pump. So Medtronic makes a ton of pumps, for example. If we get people in our ED with malfunctioning pumps, they call Medtronic. Medtronic has them run through some tests, and then we'll tell them, go to the emergency room, we'll send you a new pump in a couple days, something like that. Oh, and just the final bullet, the second to last bullet point, highly compliant patient. So pump dosing, while it seems pretty straightforward, it requires you to be really on top of it. You have to know how to deal with a pump. You have to know how to prime the tubing. You have to know how to refill it. You have to know how to be able to react to a malfunction. So all that stuff requires a patient who's somewhat tech savvy and able to be able to show that they have the competence to do that. And not all patients will be able to do that. Okay, hypoglycemia, biggest side effect with insulin across the board. The other side effect would be injection site irritation or possibly anaphylaxis if somebody reacted to the insulin, but very rare. Hypoglycemia is your biggest risk here, and it's usually defined as blood sugar below 70. Insulin is going to carry the highest risk out of any of our anti-diabetic medications. Usually the best way to treat it is consume 15 to 20 grams of glucose or another simple sugar you have available. Not all people have just pure glucose at their disposal. While there are products on the market designed for diabetics, some people might have access to like a pop or something like that they can drink really quickly. Whatever you can get, if you aren't in immediate vicinity of some kind of emergency services, is going to be better than nothing if you're hypoglycemic. In severe cases, if people's blood sugars get really low, you're looking at neurologic deficits, coma, seizures, and ultimately death potentially. In really severe cases, or even in slightly emergent cases, if the patient has IV access, IV dextrose is an option for us, and that's one that can get the blood sugar back on board really fast. Symptoms of hypoglycemia, you guys have probably covered this in other classes, but I like to think about it when I get really hungry. I get kind of like mild hypoglycemic symptoms, get kind of irritated and upset, hangry, if you will. Glucagon is another option for emergency use. So I think about it's saying is when glucose is gone, you use glucagon. I always remember it that way. It's a peptide hormone produced by pancreatic alpha cells, and it's an endogenous thing that we can supplement using a product that we have available to us. Glucagon comes in like a red kit like this for emergency use for outpatient. It's a vial and a syringe, so you actually have to pull it out and inject it. I think it has a reconstitutable agent in it, so it has a better of a half-life and storage, so people can carry it with them like in a in a bag or in their car or something. Synthetic version, given in emergency situations. IV dextrose is going to be a much better option in all cases. But IV dextrose syringes are really big. It's like 50 mils of volume you're pushing in. And that's just not going to be something people carry around with them. And it requires IV access. This you can give IM or sub-Q, and it's going to work pretty quickly. So while if you're working inpatient medicine, this is never something we use in emergencies. However, in the cases of outpatient use or community use, it's a valuable tool. Yeah.
That's so faster than sugar.
Probably. It depends on how you give it. I'd say IM for sure. Sub-Q might be debatable. It depends probably on how much you have. I assume if you're hypoglycemic, you don't have much in your stomach, but depends on your GI transit time and those types of things. But you'd think pretty fast absorption, especially even in the oral mucosa with some sugar. Yeah.
Because it is used more when somebody like passed out.
Sure.
Like they couldn't.
Right. If somebody's on the verge, it's like, or they're just starting to feel shaky, or they get sweaty or tachycardic, they usually know that's the sign, and then they can take something. Yeah. Yep. That's a good point. So. Yep. Yep. Exactly. Yep. So yes, stratifying the emergence of the situation for sure. Yep. All right. Diabetic ketoacidosis is a metabolic acidosis with the anion gap that usually involves a high blood sugar, but usually a blood sugar that's below 800. So maybe 600 to 800, something like that would be a common DKA picture. You can have lower blood sugars too. I'm not going to get too much into this. I'll talk about it very briefly. We're going to talk about it a little bit more during emergency medicine. But basically, you want to do fluid replacement. And one thing that, and you're going to prep the person for IV insulin administration. You want to get that blood sugar back down, and that usually normalizes the situation. This isn't usually a problem that's fatal. Somebody catches it early, they come in, we can correct it. There's some complications potentially, but I always say it's much better to have high blood sugar than really low blood sugar. So in this case, if you give somebody IV insulin at pretty high doses, insulin also drives circulating potassium into cells. And so that's going to cause their K to drop pretty substantially in a lot of patients. And we usually fluid replace, and sometimes you might need to add potassium, or you might even need to supplement potassium to get them back up before you start IV insulin. So it's just something to keep in mind. We'll talk a lot about that a lot more when we talk about specifically some different types of treatment for emergency medicine when we talk about things like calcium channel and beta blocker overdoses and things like that. But for the most part, high dose insulin, IV, regular insulin, and you're going to monitor blood glucose and also potassium fairly regularly until the person stabilizes. HHS is very similar in treatment to DKA. It's just it's a different mechanism. So little to no ketoacidosis accumulation. DKA much more heavily associated with type 1 diabetics. HHS much more heavily associated with type 2. Again, same treatment. And usually you're going to see when you see really sky-high blood sugars, like over 1,000, that's usually an HHS and not a DKA. Although I've seen people with DKA with really, really high blood sugar too, so it just depends. There's no hard limit, but generally that's the trends you'll see. All right, type 2 diabetes, this is my joke. You think about like a type 1 diabetic patient is generally kind of lean, and then a type 2 diabetic might have some more adipose tissue hanging around. Disclaimer, I don't think either of these people have, I don't know. I'm pretty sure Michael Phelps does not have type 1 diabetes, but I don't know about that other gentleman. All right, so talking about type 1 or type 2, let's get into a little bit of it, and then we can take a quick break here. So you've got a couple of things that all fluctuate around type 2 diabetes and all increase risk of complications, which we already talked about. Smoking, blood pressure, cholesterol, sedentary lifestyles, those can all contribute and exacerbate type 2 diabetes. And essentially you just have a situation where somebody has had so much glucose in their body for a long period of time that their muscles can't use it. You have too much. You're just not using all that's available. So your body tries to store it, it tries to metabolize it, and ultimately you get complications associated with that. Can't talk about diabetes without talking about sugar. I'm not here to preach any type of nutrition or anti-sugar thing, although safe to say that Americans consume a lot of sugar, right? This infographic just talks about like different types of sugar, and yes, drinking straight fruit juice is still consuming sugar, even though it's fruit and healthy for you, whatever. You guys know this stuff. It's pretty common sense, I think. But anyway, Increasing body weight increases risk of diabetes. Just a study that was done in '89, so it's kind of an old study, but it showed that patients with increased percentage over what they considered to be desirable weight, I'm not sure if they used ideal or corrected or what, but the increases in diagnosis and diagnosed and undiagnosed diabetes went up substantially. So my point in showing you this is diabetes certainly has a lot of lifestyle modifications that can be really advantageous to implement to reduce the disease risk and ultimately the disease's impact on the patient. However, are people going to respond to those interventions, and are they actually going to follow through with them or keep them long term? That's a really great question, and it's going to depend on your patient for sure. Okay, so we're looking at about 8% of the U.S. population affected with type 2 diabetes, so a huge number of people. 25 to 40% of type 2s are probably undiagnosed, and 90% of all diabetic patients are type 2, the remaining being, of course, type 1, or possibly like gestational to qualify for that too, but again, very small percentage compared to the majority. Normal labs, fasting blood glucose should be below 100, and your A1C generally, per the guidelines for most patient populations, should be below 6.5%. And that's where your screening tools come into play too. What's your fasting blood glucose? What's the A1C look like? And if their fasting blood glucose is over 126, it's a 2-hour blood glucose with a tolerance test greater than 200. So we'll talk about tolerance tests a little bit more with gestational. Essentially, give the person a bunch of sugar, wait 2 hours, test their blood sugar, and that should give you a response on how well the person's body can react to a sugar spike. And in the case of not coming down below 200, that would be a diagnostic criteria for type 2 diabetes. Hemoglobin A1C, you've got glycosylated hemoglobin, and that's going to show you, again, your long-term chronic picture versus the individual snapshot that a blood glucose will show you. I'm not going to make you memorize guidelines, although we're going to talk about them a lot today. So there's 2 major sets of guidelines that dictate how we well, I don't know if dictate's a good word. That's the word I'm going to use. How we practice type 2 diabetes management, and they are the ADA guidelines, American Diabetes Association, and the AACE, or American Association of College of Endocrinology. And they have a little bit difference of opinions. So you can see, like, pregnant patients, actually, they recommend a much more aggressive A1C goal than ADA, and generally a little bit more aggressive across the board. So again, does it matter what goals you go with? I don't know. That'd be a debate between the ADA and the endocrinologist. So do you want to get involved with that? I don't know. But there's 2 separate sets of goals. So I think if your patient's within range, you can probably consider, pretty good for the most part. All right, we'll talk about non-farm options and then take a quick break before we get into drugs. Again, diet and exercise can have huge impacts on people's diabetes. There's no question about that. So calorie restriction, food choices, and carb counting, all things that, again, your friendly dietitians can help you out with. Exercise programs, even mild exercise, like it doesn't have to be, they don't have to pick up CrossFit the next day. They can go do, walk a flight of stairs at their work, go walk around their building at lunch. Little things like that can actually have a decent impact over time. Using your muscles improves blood glucose utilization, which increases insulin responsiveness. It's just the way the body works. You get to a point where your diabetes is so uncontrolled that nothing's really going to help other than supplementing with insulin. But if we can get to our patients before they get there with some of these modifications and maybe some medications, that's ideal. In case you're wondering how effective this is, there's a big study that looked at, it was called the UKPDS, which I can't remember exactly what it stands for. It was a British study that looked at diabetes and lifestyle modification. And they looked at low calorie, low fat, and including high complex carbs versus like low simple sugar diet. And whether that's an ideal diet or not, I'm not going to debate that. But anyway, it was supposed to be a calorie controlled diet with minimal simple sugars. And about 3% actually achieved their fasting blood glucose goals using this specific diet. And they also had an exercise component, which was shown to be helpful and good at the beginning, but compliance was almost universal, that no one kept up with the exercise program at the follow-up points later in the study. So the point in this is again, it's good to say this, and yes, it does make a difference, but can you get a patient to actually commit to it? That can be really tough. And I'm not saying we should give up on people and just say, just eat whatever you want, we'll give you more metformin. We can try and be strategic about this, of course, but it's difficult, and oftentimes we're fighting an uphill battle. So what I say is that use your resources, use your dietitians, use your skills as a provider. When you talk about meds, consult your pharmacist. Make sure, a lot of pharmacists work in ambulatory care settings, and we'll tweak medication regimens. We'll talk about medication adherence and also do some lifestyle education. So keep educating on lifestyle, do it incrementally at every point in the visit, and maybe something will stick. All right, let's take a quick 5-minute break, and again, I'll try and get you guys out of here by 5 o'clock tonight. Okay, I don't know if everyone's back yet, but let's keep rolling here. We got a few drugs to cover, and they're all new, which is probably what you want to hear, right? Diabetic medications, before I talk about metformin, are a little bit tricky, just because there's a lot of different oral classes out there, and the guidelines are a little bit sketchy on what you should use them in. I know that's what students hate, but I can't give you I can give you a first line, so that's what I'm going to give you. Metformin, there you go. Take that one to the bank. Metformin's a drug that's first line across the board in all diabetes guidelines. It's recommended as the initial therapy. The reason is it's highly effective and the side effects are very minimal, with the exception of some GI things that can cause discomfort. Mechanism, it's going to decrease hepatic glucose production and decrease intestinal absorption of glucose, and also increase peripheral utilization and uptake. The thing you will notice about metformin that you won't really notice about any other medications, it does not do anything with insulin. It doesn't manipulate the pancreas. It doesn't produce more insulin. It doesn't do it. Therefore, you have virtually no risk of hypoglycemia with metformin, which makes metformin a hugely advantageous drug to use. Anything that causes hypoglycemia puts people at risk for side effects, right? So this is taking that side effect pretty much out of the board, or off the board. What you'll see sometimes is people will say, well, you could possibly get hypoglycemic on metformin. Mechanistically, it's not possible to get clinically significantly hypoglycemic on metformin. So I'm just going to say that out loud, but you might have people who disagree with me on that. But that's just, from a mechanism of action perspective, explain to me how that would happen. You might get slight dips, and that's how the drug works, right? It's going to use some glucose. Reduction in A1C is pretty huge, 1.5%, which is one of the biggest out of any oral medication. Contraindications. This is a new recommendation, actually. Metformin's a really old drug, but there was a bunch of new studies that looked at specifically renal elimination of metformin. So actually, this is one of the weird instances where they actually use estimated GFR. So they use the MDRD equation to calculate people's kidney function, whether it was appropriately clearing it or not. And so people with an estimated GFR less than 30, contraindicated. Previously, it was all about serum creatinine. And so they said if your serum creatinine was 1.4 in men and like 1.5 in women, or vice versa, I can't remember, you were contraindicated to using that. But for now, it's back to the clearance, which is nice. And since most places report specially to providers in EGFR, in terms of EGFR calculation, this is a nice tool to have. And I think as we see older drugs get more action as far as evidence-based studies looking at renal elimination, you're going to see more things convert to EGFR, but again, creatinine clearance is the primarily one.
Is this allowing more people to be able to use metformin?
Probably because it takes away some of the... So when you're just looking at serum creatinine, you're looking at a number of other things. So somebody could have a serum creatinine of 1.4 and still calculate decently with their EGFR, if they're younger or heavier, potentially. So, yeah. So, yeah, for sure. I think you would probably see a higher amount of people being able to use it. You do want to hold with IV iodinated contrast media or surgical procedures. The reason being is metformin and contrast media, there's some instances of lactic acidosis potentially and kidney damage with those two combinations. So that's one temporary contraindication. So that one, eliminates somebody for life. That's just, there's some guidelines on when to hold it and when to use it. Side effects, again, lactic acidosis, super rare and thought to be associated with renal dysfunction. There's a lot of opinion out there that says metformin actually doesn't cause lactic acidosis at all, and we don't have any good evidence that actually proves that. And if you look into it, you'll find that you'd probably agree with that. But there is some association with it, so we do say that, again, there's that contraindication with certain renal dysfunction, and there is that risk. Diarrhea and GI side effects is probably the worst complication that'll get people off the drug and cause discontinuation. But metformin comes as an extended release product and a regular release. So if somebody has GI side effects on the regular release, put them on the ER. In fact, you might just want to start on the ER. They're both generic and they're both very affordable, so it doesn't really matter where you start. I'd recommend starting extended release for the majority of your patients. It's probably going to limit that side effect profile down to the lower end of that range versus the higher end. And now we're getting into a number of different classes that are all kind of in no man's land when it comes to what do we pick next. So I'll talk about some of their advantages and disadvantages, and then we'll talk about the guidelines. Sulfonylureas were a long time, have been for pretty much, the majority of, the last couple of decades been the second line therapy to metformin. They're actually pretty effective A1C reducers. However, their problems are substantial. They have the highest hypoglycemic risk out of all oral hypoglycemic agents. So they're going to cause the largest amount of clinically significant hypoglycemia. That's because they stimulate insulin release from the beta cells. And there's a lot of theory that mechanism actually causes pancreatic damage over time, and you're actually overtaxing your beta cells by using sulfonylureas. So some of the newer theories, especially with the endocrinologists, and I refer to the AACE guidelines as the endocrinologists, they don't like sulfonylureas, actually put them at the very bottom of their choice. So where these have been historically second line, they're actually falling almost completely out of favor. However, they're cheap, and a lot of patients still take them. So you're going to run into these prevalently. So I don't want to make it sound like no one takes these, because actually this is probably one of the most common classes of diabetic medications you're going to see out there. So again, some differences between what the guidelines say and what we're actually doing in real life. But a lot of it's because patients have been on it for a while, they're stable, we know how they work, and if you don't have poor renal function, you're eliminating them correctly and dosing them correctly, the hypoglycemic risk should be fairly minimal. The other thing is they cause weight gain, and some of our drugs, of course, have the opposite effect where they can help with weight loss, which is usually going to be preferred for a type 2 diabetic. Okay, 3 different sulfonylureas: glipizide, glyburide, and glimepiride. Glipizide is one to remember out of the 3. It's no renal adjustment needed. So if you have a patient with renal dysfunction, this is the one they should be on. You shouldn't even consider the other 2. Glyburide, I say renal adjustment not needed, but actually it is renally eliminated to a certain standpoint. It's got a longer half-life, so if it is accumulating, it can be more problematic. And again, hypoglycemic after exercise or missed meals specifically. If somebody skips meals, they should probably skip their sulfonylurea just to be safe, especially if it's twice daily, which is how glipizide is dosed for most things. Thiazolidinedione, which is a fun word to say, are a class of drugs, and there's only actually one here that we still use. It's pioglitazone, which is Actos. Actos and Avandia, its counterpart, have had an interesting history in the U.S. market. There are 2 on the market that came out right away, and there are these 2. Rosiglitazone was removed from the market in Europe and then highly restricted in the U.S. virtually immediately due to some increased risk of myocardial infarction. The FDA actually reversed this decision in 2013, which made the drug company really happy, probably, right? Because they probably lost billions of dollars in revenue. So there's probably ongoing legal action going on about this, but that's beside the point. Pioglitazone is the one that people still use. I think even though rosiglitazone's restrictions were reversed, people are still pretty hesitant about it because it was so restricted for such a long period of time that it just kind of sticks in people's minds. Interestingly enough, pioglitazone was removed in France and Germany off the market due to bladder cancer risk, and also saying that we don't need this drug, basically. We have other drugs that work great. This one might cause bladder cancer, so why are we using it? That's kind of the moral of the story with the thiazolidinedione class, is that we have some better drugs in the market. Do these have some role? Yes. Are they the best drugs we have that are hypoglycemic agents? Probably not. Their mechanism is they're a PPAR gamma agonist, which activates a gene that involves glucose and lipid metabolism, and they improve target cell response to insulin. Interestingly enough, this does not increase insulin secretion, so your hypoglycemic risk with these, like metformin, is very, very low. So that's a nice advantage with them potentially. They also have some decent A1C lowering potential. So this isn't a useless drug class. It's just due to some of the weird stigma around it, like cancer risk, vague cancer risk in some countries, myocardial infarction elevation, people are not real comfortable with them overall. The other side effect is fluid weight gain. So in all patients, that's a negative for diabetes type 2. So that's a check against it right there. And also for heart failure patients, it causes fluid retention. And so it's generally speaking a contraindicated for heart failure. So that would be a way that we would maybe narrow our therapeutic choices in patients. So if you're going down the guidelines and looking at, okay, these are my options, my patient has heart failure, I'm going to avoid this class altogether. Yeah.
How they're causing weight gain?
I don't know exactly how. I believe it's the way that the glucose uptake happens that increases. Things that increase insulin are actually insulin. If you supplement with insulin in a type 2 patient, insulin itself causes weight gain. So it's something to do with the way that the body's using insulin, but I'm not exactly sure why. Because physiologically, it's beyond my scope, I think. DP4 inhibitors are, or DPP4, excuse me, are all end in gliptin. So you can remember the suffix and know them all. They all have the same mechanism. They're all essentially interchangeable for the most part with some subtle differences. But their mechanism is that they prolong incretin hormone levels, which allows for a couple of things to happen. So dipeptidyl peptidase 4 is the abbreviation here. It's an enzyme which inactivates incretin hormones. So you're inhibiting that enzyme. Therefore, you're getting more incretin involved, which helps increase insulin secretion from the bile cells. So you're indirectly helping the pancreas release more insulin. Modest A1C lowering effects. It does seem to be clinically synergistic with metformin. So if you combine it with that one, you do get more of a bang for your buck than if you were just to give it alone or with another agent that isn't metformin. They're relatively expensive. They're brand name only. Hypoglycemic risk is quite low, even though they increase insulin secretion. There seems to be some sort of a rate limiting factor there, and they're pretty well tolerated. So this is a relatively popular drug to pick as sort of do I do it second line or third line or fourth line? Depends on what you're looking at and where your patient's going to fall. And again, we'll talk about some of those guideline recommendations here in a minute. But some side effects. FDA has a warning with joint pain. There are 33 cases over a 7-year period. I don't know if this is something we care that much about. But basically, if somebody has symptoms 1 month after they start, and it resolves 1 month after they stop. So it's directly related to the drugs. If you get a patient on this, they get joint pain, just have that in the back of your head. It's an odd, rare side effect, so don't worry too much about it. There was also some evidence with saxagliptin and alogliptin that people with heart failure had increases in hospitalization. So one of the subsets of diabetes that's really heavily watched right now is cardiac-related issues, and specifically heart failure patients, because so often they go hand in hand, and the question is, do some of these drugs have positive mortality benefits in our heart failure patient population? So there's been a lot of evidence in the last few years looking at this. So that's why I'm bringing this up with a couple of these different drug classes. But this one does seem to have an increased risk. So is it contraindicated in heart failure patients like the thiazolidinediones? Probably not, but is it not recommended? I'd say maybe lower on your list for a heart failure patient. And then there's a combination with linagliptin and the next class of drugs recently approved. So just like blood pressure meds with diabetic medications, you see a lot of combo products. You see a lot of like metformin, glipizide type combos on the market that exist to decrease pill burden in patients, so not uncommon to see that strategy used. The next class is sodium glucose cotransporter 2, or SGLT2 inhibitors. Diabetic drugs love acronyms, as you guys are probably already confused by. I get confused by these too. So my biggest thing to remember, my biggest advice is to remember the prefix or the suffix of the drug name. That's going to help you identify them on an exam, probably the best. Other than, I'm going to tell you what it is, sodium glucose cotransporter, but it's not going to ring a bell. So if you can remember the prefix or the suffix, excuse me, maybe that'll help you. I don't know. That helps me a little bit more. Think of these as like the gliflozins than the SGLT2 inhibitors. But that's just me. Anyway, these drugs, their mechanism is kind of self-explanatory with their name. They're reducing resorption of filtered glucose, or urinating out more glucose, therefore you have less circulating. So it's an interesting mechanism. It's a novel mechanism that's new. These drugs are new within the last probably 3 years. And people end up basically urinating out about 200 to 300 extra calories, and this causes a decent amount of weight loss too. So another advantage, 2 to 3 kilograms reduction over 6 to 12 months was seen and sustained in clinical trials. So some interesting evidence making these drugs look kind of attractive. Renal dosing. So because these work in the kidneys, they aren't recommended for anyone at the GFR less than 60. So it's going to eliminate a huge amount of your diabetic patients, especially advanced diabetes and elderly patients. Gone. But for younger patients, new diabetics, this might have a nice advantage to it. We'll talk about some of the other side effects, which kind of got a lengthy list here. But there are some evidence, so contraindicated if less than GFR is less than 30. And then there's some supporting evidence that you can reduce your dose of canagliflozin between 40 and 60. So there's some evidence. Basically, if you don't have healthy kidneys, these drugs aren't going to be fully beneficial for your patients. They have to get into the kidneys and be able to use the kidneys to remove glucose, or they aren't going to work. So if your kidney function is diminished, not only is it risk for accumulation and maybe more side effects potentially, but you're not going to get as much benefit from the drug itself. Okay, mild hypoglycemia, not generally thought of as a clinically significant hypoglycemic causing agent. Hypovolemia can cause hypotension, dehydration. So this drug is kind of like a diuretic if you think about it. It's going to increase fluid and glucose elimination. So staying hydrated is important. And then you've got possible increases in serum creatinine. Whether people are getting acute kidney injury due to the actual drug or due to dehydration is questionable. But either way, it's putting people at risk for it. Increases in LDL have been seen, bad cholesterol. We don't know why. That's a question mark. Now, these ones are where it gets kind of interesting, I think, the ID related. Fungal vaginosis, UTI, balanitis in men, all related probably to the fact that there's sugar in that area of the body, and then organisms take opportunity with the extra food source and can multiply. That's the theory behind why these drugs cause these weird ID-related side effects. But the thing to think about is if the patient's prone to this stuff to begin with, they're probably not going to get any help from this drug. It's going to make it worse. And it's actually pretty common with this medication. So when these first came out, everybody's like, well, what's the point? They don't work in people with poor kidney function, and they cause everyone to have yeast infections. Why would I want to give this to anyone? Well, they do have some interesting advantages. They have decent A1C lowering effects, and they actually have some positive mortality benefits and CV outcomes studied in separate studies. So while they look kind of shaky on one side, they actually might have some advantages on the other. The other problem is, and I put on the slide, is these are expensive. 3 years old. Insurances don't necessarily like them. So while you might have an endocrinologist, and I think I had this passed in the class where somebody's like, well, the endocrinologist we talked to or came in said these were great. Well, yeah, if you can get somebody to pay for them, they could be really great in the right patient population. And I would say for your younger, early diabetic patients, this is actually a pretty good choice to put someone on if the insurance pays for it. That's the big caveat, I think, for a lot of people. All right, GLP drugs, glucagon-like peptide agonists. These are, again, the name kind of says what they do, which is nice. Short-acting and long-acting formulations. The short-acting ones have pretty much fallen out of favor for the long-acting. The data is just way better with the long-acting products. Essentially, these are increasing glucose-dependent insulin secretion, decreasing inappropriate glucagon secretion, and slowing gastric emptying and decreasing food intake overall. So people actually lose a decent amount of weight with these, which is, again, an advantage for our medications here. They're sub-Q injections. They're expensive. A couple of them actually have to be reconstituted before they're injected too. And the dosing schedules vary. Some are like once weekly, some are every other week, some are a couple times a week. It depends on the product and if it's short or long-acting. But usually the long-acting ones, most of them are like once weekly injection. It's a pretty common dosing strategy. And you can see they all have the same name, glutide for the most part, Exenit, and then the tides. If you remember then tide, you should be able to recognize these guys. Again, advantages, again, weight loss, low risk of hypoglycemia. These are being studied in CV risk just like everything else. And some of them are showing maybe some early promise and having some cardiovascular benefit and mortality benefit as well. Not as much robust data as with the SLG2s so far. Side effects, GI related, nausea and vomiting, about 10 to 50% of patients. Why exactly this happens, I'm not 100% sure. Something to do with the way it's affecting the GI tract absorption potentially of certain glucose potentially as like a side effect or a side, not necessarily side effect, but a side mechanism of the way that it's causing insulin secretion and other mechanisms. But I'm not 100% sure why that happens. And it's a really wide variety of patients. Usually the longer acting products are better tolerated overall. So not a total reason not to prescribe it, but something to consider. They're renally eliminated and dosed. So that's something to consider too. Usually it's pretty liberal as far as how far down you can get with a renally compromised patient when you can give it, but it is there. And thyroid tumors in animals, so possibly a risk, but not something that's been seen in humans so far. All right, the last category of actually useful oral drugs, the next slide is pretty much just a waste of time, but we'll talk about it briefly anyway. Meglitinides are listed there. There's 2 of these available. Repaglinide is a no renal adjustment med, which is always nice, and has also been clinically shown to be more effective than its sister drug, whatever, Starlix, I'll just use the brand name, I can't say it right now, which is renally eliminated and has metabolites. Mechanism of action. Blocks ATP-dependent potassium channels, which causes calcium entry into beta cells due to membrane depolarization, which stimulates glucose-dependent insulin release. So another drug that's pretty much manipulating the way the body's releasing insulin. Similar or slightly less effective than sulfonylureas with lower hypoglycemic risk than the sulfonylureas. Generally thought of as a sulfonylurea substitute, especially if a patient is on a sulfonylurea and doing okay, but has erratic meal times. This can be a one that has less hypoglycemic risk and works similarly and has a similar efficacy rate. So it's thought of as an alternative, but certainly could be added on to any number of regimens. These are brand-only drugs, and they're relatively expensive. Alpha-glucosidase inhibitors, again, I'm not going to spend a lot of time on these. They basically work in the GI tract. They cause a lot of side effects that are GI-related. Their A1C lowering benefits aren't great, and you're rarely going to see these used. So that's all I'm going to say about them. I won't test you on those medications. Insulin in type 2, historically, this was reserved for failure, or you're taking 4 oral classes and it's not working. Some of the guidelines are saying let's start this earlier, especially if people have higher A1Cs. So like if your A1C is 10 or 12% when you're showing up, let's start you on insulin right away instead of messing around with orals. Now you might get some patients that are like, I'm not going to do that. I'm not going to inject myself. Try something else. And then you have a good conversation with them and end up saying, okay, well, let's try orals and see what happens, oral and lifestyle. But guidelines would recommend to start aggressively in some patients. But basically, you're either going to do it in 2 strategies. You're going to start with somebody who's really uncontrolled and do insulin right off the bat, or you're going to work your way up to that with oral therapies and add on different orals. You get to 3 oral medications, still not getting good control. That's probably time to switch to insulin at that point. Insulin with this management style is different than your type 1. Usually you're looking at starting somebody with basal, maybe adding basal onto their metformin regimen. You can combine orals and insulin for sure. You can do both. And that's pretty common actually. A lot of times you'll see somebody on metformin, maybe one other oral plus basal insulin. But you can do intensive insulin as well. That'd be kind of the last step with the type 2 is to do basically type 1 style management on them. This older chart from Up to Date shows, I think, a nice simple way to manage type 2 diabetes. It says, so here you go, you have lifestyle and metformin at diagnosis. If that's not going well, consider adding insulin or consider adding a sulfonylurea. And then if that doesn't go well, add intensive insulin. Now it has all these less validated therapies that don't have as much evidence. The current guidelines would say, don't use sulfonylureas. We don't like that as much. So let's talk about those a little bit more. Oops, where's my slide? There it is. Okay, so this is the ADA guidelines, and they say, okay, start with lifestyle, initiate metformin. If your A1C is not achieved after 3 months, you're going to add a second agent. They don't specify in the guidelines which agent to pick, although they talk about the agents like I talked about them. So does your patient have heart failure? Is your patient young and healthy? Like, which one do you necessarily pick? And there isn't really a right answer to this. And you'll see that the endocrinology guidelines are different, and they have more of a hierarchy, which might make things a little easier to understand. But ultimately, there's not a lot of evidence that says we can't use sulfonylureas. Yes, theoretically, do they tax your beta cells more so than other drugs? Possibly. But again, we don't have a lot of long-term evidence to support that we don't use them anymore. Again, a lot of people use them. So do you pick one, or which one do you go with? Well, again, it depends on some of those patient-specific factors. Is weight gain a big attractive factor for your patient? Maybe you do a GLP or an SGLT2. Those might be good ones to get some of that weight off the patient, help them out with their exercise regimen. So again, it's hard to say which one you go with, but the way I'll phrase test questions is I'm going to focus on the advantages of medication. So know the ones that cause weight loss, know ones that cause weight gain, know some of those specific side effects, which ones are contraindicated in heart failure patients. That could come up on an exam too. Which ones have problems with renal dysfunction, which ones are better for renal patients. So I'll try and direct you that way versus giving you like, okay, your patient's on metformin, they aren't controlled, here's 4 classes of drugs, pick one. I'm not going to give you that. I'll give you more information than that. Hopefully you'll be a little bit clearer on the exam. But I know this is a little bit confusing, and I'm confused by it too, just to be frank. It's hard to keep up with it all. So what they say is after you add your second agent, then you're going to look at your third agent after that 3-month period, and you're uncontrolled. And this is where they say, so if you started a sulfonylurea, you would add on some of these. And this is based on some synergistic data. But you see they're still putting sulfonylureas up as one of their preferred choices. Now, is this in order? Kind of. The ADA still generally likes sulfonylureas, much more so than the endocrinology. But really, you could do anything. So you can combine a lot of these agents with each other. So when you get to third therapies, it gets like, it's kind of a crapshoot. Pick one, hope you get some control. Now, if you do a triple therapy on somebody, you don't get control. You're looking at moving to injectables, If you haven't added basal insulin already, you probably should consider that. Or you could consider even mealtime insulin in some patients if you have optimally titrated basal insulin. So it just depends on where you go with that patient. But you can combine a lot of these different therapies together.
So then would you stop the triple therapy and then just go to insulin and then just forward?
You could try. It depends on what your triple therapy is. So if you went with like, if your third agent, if your second agent is basal insulin, so let's say you add basal right onto your metformin, then yeah, maybe you want to add mealtime. You could keep the metformin going too. There's no real reason not to, and see where it goes. So it just depends on how you want to approach it with the patient, how much benefit you think they're getting from the current therapy. But I wouldn't have somebody on like 3 random orals plus intensive insulin. I'd probably like keep the metformin as a core regimen and maybe knock off the other ones and then start an insulin regimen, just so you aren't risking too much hypoglycemia, especially with some of those other agents that manipulate insulin release. Okay, and now for the endocrinology college's guidelines, a little bit different, but also kind of similar. So entry A1C less than 7.5, but still not at goal, monotherapy with metformin. And this one, actually, they did put these in order of their preference. So whereas ADA, it's kind of like that is or. Well, they don't really have they're making a specific recommendation. AACE, did do that. So they think metformin's your best monotherapy, and they actually think GLP-1s would be your second choice, which is interesting. That's one of the first sets of guidelines that said, yep, we love these drugs, let's use them. And I think a lot of their data around weight loss and efficacy and patient tolerability is really good. So especially with the extended release, newer formulations. And you'll see sulfonylureas are smack dab at the bottom, so they don't like them. If your entry A1C is greater than 7.5, they want you to start your patient on 2 drugs at once. So they want metformin plus GLP-1. And again, they also like the SGLT2s quite a bit more so than what we've thought about previously as them as a useful drug. So they like the evidence that's coming out, the trend that's going in that direction. Will that be something we see long term? It's hard to say, but they're on board with it. Triple therapy would be for somebody with A1C over 9, so that's 3 different agents. If you have no symptoms, with A1C greater than 9, dual therapy or triple therapy could be considered. If you have symptoms, insulin plus other agents would be considered at that point. So they kind of just throw insulin in there. They don't really give a recommendation of basal versus mealtime. They're just saying consider an insulin regimen of some kind. Yeah.
In the dual therapy, are they saying metformin or one of the others and then go right to basal insulin? Is that what they're saying for dual therapy?
Yeah, they're saying it depends on what you started with in monotherapy. So if you started with a GLP-1, they're saying keep that one on, but then add something on board too.
And another oral agent or
you could do either one, yeah. So they're saying basal insulin. So insulin causes weight gain, and insulin, there's some theory that it's just not good long-term management for type 2 diabetes. But so they put it as a lower choice. But yeah, you could pick it as a secondary option. And so the only reason you would be at this step and not use metformin is for tolerability issues or contraindication via renal function. Okay, that's the last slide. Again, these guidelines are a little bit complicated. I recommend just looking through the drugs and looking over the guidelines and seeing if they make sense. I have a case for you for, I think, the next set of slides. We'll talk about some stuff. So we'll do that next week. But otherwise, hopefully we braved the traffic home okay. And I will see you guys next Monday.